Now, basically, what we have discussed is, see, from the starting we have discussed the general difference between primary and permanency. Now, what is the etiology of pulse pathology and the diagnosis? This. Now, what are the objectives of pulsar therapy? So, we have discussed that there is certain stimulatory factors that occurs and there is pulse pathology. Then we have discussed how we can diagnose pulsar pathology. We can evaluate the pain, swelling. We can evaluate there is Pulp testing system, and we can lead to the diagnosis. Yes, there is a kind of pulsar pathology into the tooth. So now, what are the objectives of the therapy? So in primary dentation, the main objective is to maintain the integrity of the arch line. Basically, a from primary tooth does they maintain the arch line integrity, and also they maintain the aesthetic mastication, speech, and physiological effects. Uh, we need to maintain pulse therapy. We need to do pulse therapy to maintain the various things like aesthetic of the patient, the function of the patient, the masticatory function of the patient. Then the speech is also connected to with the things, and the psychological effect is also there. So we need to maintain it. So first of all, the main objective of pulse therapy is to maintain the arch line, then to maintain the function, and to create a healthy oral environment, to relieve the pain that and contribute to the development and maturation, growth of facial skeletal complex. And also, what are the effects of caries tooth on the subclavian? Effects of caries tooth on the subclavian tooth on peripheral tissue and systemic condition of the child. So basically, if there is infection in your primary tooth, it may uh, percolate towards the subcutaneous tooth also, and there can be certain problems in development of the subcutaneous. Now, what are the pulse therapy procedures? Basically, conservative procedures, and there is not much removal of your tooth structure and radical procedure. Now, conservative, there is indirect pulse capping, direct pulse capping, pulse waterning, radical means pulsectomy, and now indirect pulse capping. Basically, what is indirect pulse capping? Indirect pulse capping is a procedure in which respiratory material or medicament is placed on the floor of the pulse where there is no direct contact with the pulse surface. So basically, according to McDonald's, indirect pulse capping is a procedure in which only gross caries is removed from the lesion and the cavity is sealed for a time with a biochemical sealing material. According to Engel, it is procedure wherein small amount of various density is retained in these areas of the cavity preparation to avoid exposure of pulse, followed by placement of a suitable medicament, restorative material that heals off the caries tension and encourages pulse recovery. So basically, we remove the caries tension in smaller amount and in deeper area, which may lead to pulse exposure. We retain the dentin, we leave the dentin in the deeper areas to avoid exposure of pulse, and then we place a suitable medicament or a restorative material over it that seals the areas dentin and encourages the recovery of pulse. So, what is the aim of IPC? That is, what is the aim of your indirect pulse therapy? Giving pulse the opportunity to recover from toxins of dental caries by judicially removing infective dentin and isolating the remaining areas legend from oral fluid with respirative muscle. So what we do in indirect pulse capping is we give pulse the opportunity to recover by sealing off the infected portion by removing the infected portion of the dental cavity and isolating the remaining carrier legend from your oral fluid. So the basically we cut off the bacterial growth and that will lead to recovery of the pulse and reparative dentin formation. Now, history says, according to Perry Foucault, all caries should not be removed in decent surgical cavity. He also advocated the same. And according to John Tomes, it is better than a layer of discolored dentin should be allowed to remain for protection of the pulse rather than run the risk of sacrificing the tooth. Now, what is the rationale? The rationale is treating asymptomatic teeth with teeth caries legend and it is reducing the risk of exposure. In 1966, Fusama says there is two layers of a caries dentin. Outer layer that is infected dentin. What is there are two layers, infected and affected. Now, infected dentin is basically present in the outer layer. It is the collagen fibers and that is irreversible in nature. They cannot be recovered back. They do not have a potential to remineralize and the number of bacteria is very much is present in the outer layer and it should be removed. So infected that is soft, leathery, blackish, soft leathery in consistency, blackish in color and it has the collagen fibers are irreversibly denatured and the dentin is incapable of remineralization. So it should be removed. But the inner layer, that is the affected dentin. Inner layer of affected dentin is reversibly denatured. The collagen fibers have the potential to gain back their thing. There is a potential of remineralization and should be preserved. Number of bacteria is very less in affected dentin. So there are two types of dentin. And the rationale is basically of indirect pulse tapping is removing the soft leathery outer layer, that is removing the infected dentin and preserving the affected dentin. So this layer is the acute lesion that is found in the outer and the inner layer. Surface is hard, deep sclerotic and it is not contaminated this one. So this is arrested lesion. So basically what we have discussed is the layer of dentin, infected and affected. Now what are the response to this? When we leave the affected dentin and place a biocompatible material over it, what is the response? The three distinct type of new dentin formation is seen. Like cellular fibrillar dentin, first 2 months, then globular dentin is first 3 months of the treatment, and tubular dentin is uniformly mineralized. So what we conclude is new dentin is faster, new dentin is formed faster, but it is thinner. Uh, Pulse increases under treatment, the new dentin and the new dentin or reparative dentin formation is more in primary than compared to permanent and more in males compared to female. Now, what are the indication of indirect pulse capping? The indication is history, tolerable dull, mild discomfort from chemical thermal stimuli, and there is absence of spontaneous pain. And the pain that subsides after removal of the stimulus. There is no history of your night pain or any history of access swelling, etc. And there is no mobility. So on clinical examination, what we see is large caries lesion. The gingiva appears to be normal The color of tooth is normal, there is no color change in the tooth, and there is no lymphadenopathy. In radiographic examination, large caries lesion close to pulse but not involved in the pulse, normal lamina dura, normal periodontal space, no interradicular periapical radiation is present. So this kind of case can be selected as for indirect pulse tapping. Now, what are the contraindications? Contraindication is history, sharp penetrating pain that persists after withdrawal of stimuli, prolonged night pain or nocturnal pain. So this kind of food is not a candidate for indirect pulse tapping. On clinical examination, there is mobility, paralysis, gingiva to the root, discoloration of tooth, and no response to pulse test. So these are the contraindications. On radiograph 8, there is large lesion with apparent pulse exposure, interrupted or broken lamina dura, widened PDL, or radiolucency about the apices and percussion area. If present, the indirect pulse tapping is contraindicated. Now, what are the materials that is used in indirect pulse tapping? First is calcium hydroxide. It was given by Harman in 1930, and there are different types of calcium hydroxide that can be used, like Pulp 10, that is 52.5% calcium hydroxide in aqueous methyl solution. Dical, that has a two-phase system, base consists of titanium dioxide in a glycol salicylate with a pigment, and catalyst contains of calcium hydroxide and zinc oxide of ethyl toluene sulfonamide. And Hydra, two-phase, consists of non-essential oil, calcium hydroxide, barium sulfate, titanium dioxide, and a resin. We can also use zinc oxide eugenol in IPC. Zinc oxide eugenol, zinc oxide insoluble in water, mild astringent effect, and it is also antiseptic. Now, zinc oxide is 42%, tabulate resin is 27%, bismuth subcarbonate 15%, barium sulfate gives the radiopacity that is 15%, and sodium borate that is 1%. Now, eugenol 4-allyl-2-methoxyphenol. Reaction chelate matrix to zinc oxide using eugenolate. pH is neutral, it is highly soluble in water and can be used in main for chemo. Then there is IRM, intermittent powder, that consists of 10 to 40% finely divided natural synthetic resin, and liquid remains the same. Low solubility and has it as put in good. Then EBA, orthobenzoic acid, ethoxybenzoic acid, that is powder addition of clouds, alumina resin, and liquid it has orthobenzoic acid. It has increased solubility in less than. You can also use tablets, zinc oxide, calcium sulfate, zinc sulfate, glycol acetate, polyvinyl acetate, polyvinyl chloride acetate, uh, triethanolamine, but it has no eugenol, but it has good seed. Now, the procedure of indirect pulse. The procedure can be divided into two appointments and a single appointment. In two appointments, what we do in first setting is we isolate the tooth, we administer local anesthesia, we outline the cavity, the soft, mushy, infective dentine is removed with the help of slow speed burr or a spoon excavator. This, the cavity is flushed and dried, and the calcium hydroxide is placed over the cover, IRN or GIC is placed over it, and after 6 to 8 weeks, we recall the patient. So this is in first sitting review. And in next sitting, that is the second appointment, we'll again re-enter. First of all, we should check whether the tooth is asymptomatic or not. If the tooth is symptomatic, like mobility, swelling, persistent pain, night pain, so we need to proceed further. And if the tooth is asymptomatic and there is no swelling, and the restoration is intact, we again give LA and isolate. We remove the calcium hydroxide and the restorative material. Uh, a layer of dehydrated flaky dentin is seen, and area where whitish and soft, that is pre-dentin. We irrigate it, we dry it. Again, we cover it with calcium hydroxide and we place the GIC as a base and final dose. Now, the rate of reparative dentin deposit. The rate of reparative dentin deposit is 1.5 μm per day. Reparative dentin formation decreases after 48 days. The color changes of the dentin from deep red root to light gray or brown, and texture from spongy and wet to hard. So the texture also changes. So basically, two appointment systems. First appointment to remove the infected dentin layer and replace the medicament over the large affected. And again we re-enter, we again remove the soft portion, and then again we place a medicament. And in single visit, it is based on clinical judgment and the type of care. Basically, to remove the carrier lesion, but the lesion close to the pulse, we leave it and we place a calcium hydroxide over the portion, and then we get proceed to final restoration. Now the second procedure is direct pulse cap. Then there is pulsar exposure, and the medicament is placed directly or is in contact with your pulpal tissue. So direct pulse capping is basically the placement of a medicament, a non-medicating material on a pulse that has been exposed in the course of excavating the last portion of deep dentinal caries or due to trauma. Now, what is the rationale of your direct pulse cap? Basically, the rationale is same as in direct pulse to encourage young healthy pulse to initiate a dentine bridge and duct walling of the exposure site. So basically, a rationale is to promote dentine bridge formation. Now, history. According to Hunter in 1883, mixture of sorghum molasses and droppings of English pap, when placed over the it initiated a dentine bridge formation. 98% success. Calcium hydroxide is most successful agent in formation of dentinal bridge, according to Nyborg in 1955. The past. Calcium hydroxide can elicit dentin bridge formation and primarity promotes internal resorption. This is a drawback of calcium hydroxide in primarity. Reasons. Why there is internal displacement for pulpotomy, not in pulse gap. First is geometry and mid. Ratio of surface area of tooth in contact with calcium are relative to the remaining tissue volume is considerably higher than in capping. In pulpotomies are performed on caries deep with inflamed. So there is more chances of internal resorption. According to Powers, inorganic calcium hydroxide and dical reported 13 to 7% failure. Now, there are many controversies against the success of DPC. Why? Because it promotes internal resorption. So, in primary tooth, direct pulse capping or pulpotomy basically is having very controversial procedure. Gracie and Border, according to Gracie and Border, No evidence that demonstrated appreciation of calcium hydroxide to coronavirus will elicit such a response. According to him, there is no internal results. Now, why suggestion for attempting calcium hydroxide direct pulp capping in primary? The fees. Calcium hydroxide. Inorganic calcium hydroxide, very basic pH it has, and it creates a zone of obliteration and coagulation necrosis superficial to the deeper zones where reparative dentin begins. According to Turner et al., pulp capped with hard setting calcium hydroxide less injurious and bridge were thinner, found no internal resorption and calcium hydroxide acceptable over non-inflamed pulp. It is biocompatible with the pulp. Now, what are the agents used in case of direct pulp? First is zinc oxide using. What? Zinc with direct contact with pulp, chronic inflammation occurs and there is lack of calcific barrier and necrosis. Now, corticosteroids and antibiotics can also be uh, placed in direct pulp capping. So it is according to Broch in 1966, we can use neomycin and hydrocortisone. And according to Bhaskar et al. In 1969, steroids like cortisone can be placed, and leader mix is also an option. It is a mixture of calcium hydroxide and prednisolone. Now the response is collagen fibers, calcium hydroxide. Collagen fibers are less irritant than minimal dentin using in A2. Fuchs et al. Found dentin back after 2 months. And in case of formocresol can also be placed. 96% clinical or radiographic success rate when kept with paste of one-third dilution formocresol mixed with zinc oxide paste and covered with reinforced zinc oxide sheet. We can also use adhesive, 4-meta adhesive, soak into pulp, polymerize and form a hybrid layer. Koch showed reparative dentin deposition without pulp pathosis. Direct bonding can also be done. Key component is multipurpose dentin bonding. Adhesive which infiltrates into acid-etched dentin forms an impermeable layer over it. Purpose. Polymeric film can be layered over the exposed site without displacing pulp tissue and onto surrounding dentin where it permeates the tubules. These adhesives are hydrophilic, light cured, and layer of composite is spread over the pulp and surrounding dentin. Primer and dentin, what are the biological properties? They work in a wet environment, hydrophilic adhesion, flow well forming continuous seal onto the dentin, and displacement of composite is prevented when we use a primer and dentin bond. But when using this kind of thing, Inofosi et al. Found chronic ulcerative pulpitis, found pulp irritation to be minimal. Cox hemostasis is crucial, and sodium hypochlorite and prevention of bacterial contamination is to be done. Prayer found premolars capped, mild inflammation remain after several. We can also use denatured albumin. It has calcium binding properties. So it forms a matrix of calcification, thereby increases chances of biological obliteration and increase in dentin bridge formation. MTA can also be used as a direct pulp capping agent. Pitts et al. And Suk et al. Found it allows some micro leakage but superior sealing ability to amalgam and zinc oxide and IRM, superior to calcium hydroxide in animal model. Bone morphogenic protein. According to URIS, demineralized bone matrix could stimulate new bone formation when implanted to ectopic sites. and demineralized dentine for both bone and dentine. Soren J. et al. Dentine formation by recombinant human osteogenic protein 1. Now after direct cultivation, nowadays it is stepwise series excavation. That is alternative vital pulse therapy technique. We excavate the caries into step by step. First point, we remove the caries enamel. Bulk of caries dentine removed by excavator, supplemented by drilling with round bore at low speed. Innermost layer was covered by calcium hydroxide and filled with zinc oxide eugenol for 8 to 10 weeks. In second appointment, excavation of round bores until hard dentine was reached. A pulp exposure had occurred. A caries-free cavity bottom. No softening of remaining dentine when examining the cavity with a blunt explorer using moderate pressure. So this is basically stepwise caries excavation. So what we have discussed is indirect pulp capping and direct pulp. Again, I need to specify one basic point in pulp therapy. We should always start our classification of pulp therapies by first is pulp capping. After pulp capping, protection of pulp by placing a liner or a base also comes under pulp therapy. So while classifying your pulp therapy, the first point is application of a liner or base, then indirect pulp capping, then direct pulp capping, and then there is pulpotomy and pulpectomy. Okay, so placement of a liner or a base also is a pulp therapy.